Hello everyone, and thanks for tuning in. This video is the first of 3 that are designed to be completed prior to attending Improvement Facilitator training on opioid process improvements. The opioid process improvement training builds on the knowledge and skills that you learned in core Improvement Facilitator training. Now, while IFs aren't meant to be opioid content experts, it is important to be able to speak the language and to have a basic understanding of the clinical side of things. So to start, we're going to do a review of terminology. There's a lot of jargon and acronyms that are associated with opioids, so we've created this one-page handout that you can refer to. Feel free to print it from our website and follow along as we set the stage for training, and then also feel free to refer back to this video if you'd like once you start engaging physicians and teams in this work. So our first definition is opioid. And opioids are a family of drugs that are usually prescribed to relieve pain. Examples include codeine, like Tylenols 2, 3, and 4, oxycodone, morphine, hydromorphone, and fentanyl. Next are benzodiazepines, and these are a family of drugs that are usually prescribed for anxiety, sleep, or seizure disorders. And examples include Valium, Xanax, and Ativan. And in the clinic, you'll probably hear these referred to as benzos. Now, OME and MME stand for oral morphine equivalent and milligram morphine equivalent. And OME and MME are used to compare the analgesic strength or pain relief of different opioid medications. So it's calculated for a 24-hour period, and it's determined using an equivalency factor to calculate the dose of morphine that would be equivalent or approximately equivalent to the opioid in question. So for example, 100 milligrams OME would be equivalent to 20 milligrams of hydromorphone, 65 milligrams of oxycodone, or 25 micrograms per hour of fentanyl. Next is OUD, or Opioid Use Disorder. And this is the clinical diagnosis that's characterized by a pattern of problematic opioid use. It's linked to clinically significant impairment of function and includes things like cravings to use opioids, continued use of opioids despite experiencing social or interpersonal problems, development of a tolerance for opioids, withdrawal symptoms, and others. OAT is opioid agonist therapy. It's an effective treatment for opioid dependency, or OUD. The treatment involves taking opioid agonist medications like Methadone or Suboxone to prevent those withdrawal symptoms, reduce the cravings, and support stabilization. Now, Methadone and Suboxone are the medications that can be used to treat OUD, and we'll go into these in a little bit more depth since you'll be hearing a lot about them. Methadone is a long-acting opioid, so it doesn't have the instantaneous mood-altering effects of other short-acting opioids. And the College of Physicians and Surgeons of Alberta, or the CPSA, no longer requires physicians to obtain approval to prescribe methadone for analgesia or pain relief for chronic pain or palliative conditions. The CPSA made this exemption to make methadone more accessible for patients who are suffering with pain. Approval, though, is still required for physicians when they're prescribing methadone to treat opioid use disorder, or OUD. So when prescribing methadone for analgesia or OUD, physicians do have to use a TPP Alberta prescription pad. And again, in the clinic, you'll hear that referred to as the triplicate pad. And another thing to note is that patients do not have to be in withdrawal in order to start methadone. Now you can see from this diagram, the yellow kind of Pac-Man circle is representing an opioid receptor. And our brains are full of thousands of these opioid receptors. And we make our own opioid. It's naturally occurring. But other opioids will also bind on this receptor. And so in this case, you can see methadone. The molecule for methadone is a full agonist, and it binds to those receptors in the brain. They're called an agonist because when our natural opioid binds to the receptor, it causes a release of dopamine, which creates feelings of well-being and lessens the perception of pain. When a full agonist binds, it increases the release of dopamine, so that response is enhanced. Now, next is buprenorphine. And this is a partial opioid agonist, which means it binds to the opioid receptor, but it has a smaller effect. It will prevent some craving and withdrawal, but it doesn't cause that full effect of an opioid like the mood effects. So you can see there's a smaller release of dopamine when a partial agonist binds. The other one to think about is naloxone, and naloxone is considered an antagonist, which means it blocks off that opioid receptor, so there is no release of dopamine in the brain. Suboxone is the brand name for a combination medication that includes buprenorphine and naloxone, and it's considered a safe medication that can be prescribed and managed in the medical home. So no prescribing course is required to maintain a prescription. However, a treatment of OUD course is recommended for initiating prescription. So patients must be in mild to moderate withdrawal in order to start Suboxone. Now, buprenorphine has less of a respiratory effect than methadone does at high doses, so that reduces the risk of overdose. Like methadone, though, it still can be misused. Someone might try to use it to get high, but that would be difficult because of that addition of naloxone. As you remember, naloxone is an antagonist, and it has a high affinity for those binding sites. So it attaches extremely strongly to the receptors, and it can actually knock other opioids off the site, and it completely blocks opioids from attaching. But when taken orally, and Suboxone is a pill, when it's taken orally, the naloxone really is not absorbed at all. But if someone were to crush the naloxone pills and inject them instead of taking them orally, the naloxone would act first, and it would block off the receptor sites, and so it would cause a withdrawal effect. Our next definition is Virtual Opioid Dependency Program, or VODP. And this is an evolution of the RODP, which is the opioid addiction treatment for rural and suburban Alberta communities. And it now is offered across the province, and it's same day. OAT medication starts 7 days a week. So this is a great option for patients who need help immediately. Harm reduction. This is a set of practical strategies that are aimed at reducing the negative consequences associated with drug use. And people often think of safe injection sites or needle recovery programs, which are forms of harm reduction. And in primary care, we also have OAT, or opioid agonist therapy, and Naloxone kits. These would be considered harm reduction. So the defining features are the focus on prevention of harm rather than on the prevention of the drug use itself, and the focus on people who continue to use the drugs. Our next definition is naloxone kits, and these are also known as overdose response kits or take-home naloxone kits. And as we learned, naloxone is an opioid agonist, meaning that it binds to the opioid receptor, but it doesn't cause any kind of effect. So these kits are small and portable and can be used to respond to and reverse opioid poisoning or overdose. Each kit has 3 vials of naloxone, 3 safety syringes, 3 alcohol wipes, a pair of gloves, 1 barrier mask for rescue breathing, and an information pamphlet that explains how to inject the naloxone. And there are 3 vials in every kit because once injected, those naloxone molecules will go and knock off the opioid molecule that is currently on the receptor sites. But the naloxone doesn't stay on forever, and it will eventually start to fall off. And so if there's still, say, heroin in the bloodstream, those heroin molecules will reattach, and the person could very easily go back into respiratory distress and overdose. So that's why there are 3 doses included, and some patients may need to have all 3 administered before they can get safely to the hospital. So that's important to know. Dependence versus addiction. So dependence is characterized by the symptoms of tolerance and withdrawal, whereas addiction is marked by a change in behavior that's caused by biochemical changes in the brain after someone has continually used opioids for some time. So different parts of the brain are responsible for each of these, so it's possible to be dependent on opioids without actually being addicted. And our final definition is a change package. And this is a quality improvement framework that really refines what the high impact changes are that are expected to recur when recommended, potentially better practices are implemented. There is a change package for opioids, and it's not the only change package. Our goal is to have many change packages for many different processes related to patients' medical home transformation. All of them will have a similar look, and they'll all contain, as well as these high impact changes, a set of potentially better practices. So these are evidence informed changes or approaches that a clinic can take that may work exactly as is, or in the context of the clinic, they may need to be adapted. So we believe that they'll work, but they need to be tested and PDSA'd within the clinic to know for sure. A change package also includes some tools and resources that can support those potentially better practices, and also some measures that are suggested that clinics can use to track their progress as they work towards those high impact changes. So there you have it. That is the set of definitions that we'd like you to come to training with at least a basic knowledge of. We hope you find that helpful, and we really look forward to seeing you at training.